Tokyolive
Endoscopy
Endoscopy 1.
1.
So hello everyone, welcome to Tokyolive Endoscopy 1. The session topics of this session is Diagnostic EUS, new trends in miniature probe and FNA. It's my great honor to introduce the co-moderator, Dr. Takao Itoi. He's a professor and the chair of gastroenterology and hepatology, Tokyo Medical University. Dr. Itoi, so please introduce the first speaker.
Thank you very much for kind introduction, Inoue Sensei. So I deeply appreciate inviting me in this wonderful conference, Tokyolive 2021. Okay, time is limited. Let's get started. I'm very happy to introduce the first speaker, Dr. Yusuke Nakai. So shortly, I'd like to introduce him. He is an associate professor of Department of Endoscopy and Endoscopic Surgery at the University of Tokyo Hospital. So notably, he had a fellowship at the University of California, Irvine from 2010 to 2012, and ran EUS from, very famous Dr. Professor Kenneth J. Chan. And we know him because he's a world-renowned US young endoscopist. His area of interest and expertise includes the diagnostic and therapeutic ERCP and EUS for pancreatic biliary diseases and oncology for pancreatic biliary cancers. So today's he talk on the techniques and the challenges in EUS-guided tissue acquisition for pancreatic biliary lesion. So Dr. Nakai, please.
Thank you, Professor Itoi, for your kind introduction. You always make me nervous because you highly talk of me. So my topic is EUS-guided tissue acquisition. Let me share my presentation. So it's my great honor to speak about EUS-guided tissue acquisition in Tokyolive Endoscopy Network. So I will talk about techniques and challenges in EUS-guided tissue acquisition for pancreatic biliary lesions. As we all know, EUS FNA was developed in 1990s by Dr. Billman. He first published the paper for EUS FNA for pancreatic lesion. And now it's established as a method for tissue acquisition for pancreatic mass. And the sensitivity of EUS FNA for pancreatic solid lesion is over 90%. And the specificity is over 95%. So in clinical practice, we always perform EUS FNA for diagnosis of pancreatic solid lesions. And it's also safe. The adverse event rate is about 2.4% in prospective study for pancreatic solid lesions. The adverse event includes pain, abdominal pain, pancreatitis, and bleeding. But it's very rare. So however, we must notice there's a long-term adverse event of tumor seeding after EUS FNA for pancreatic cancer. This is a report from Japan. In the patient with a resectable pancreatic cancer, the needle tract seeding was seen in 3.4% in this report. All the patient has a cancer in the body and the tail of the pancreas, and the needle goes through the stomach. And after surgical resection, the patient had a tumor seeding in the gastric wall, like this picture. It looks like a submucosal lesion, but actually this is a tumor seeding from the EUS FNA. So we have to be always balance the benefit and risk of EUS FNA. And nowadays, new needles, so-called FNB needles, are commonly used in clinical practice. The conventional FNA needle has an end-cut tip, but the recent FNB needle has a special tip like a fork tip needle or Francine type needle or side bevels. With these needles, it's believed to get a more specimen compared to the conventional FNA needles. However, as I previously showed, EUS FNA has a sufficient accuracy for pancreatic solid lesion. So you cannot overcome the accuracy using a new needle of FNB. In the meantime, if we perform FNB, we may not need those. With a conventional FNA needle, if we have an on-site evaluation, we can decrease the number of passes. However, in FNB needle, there is no effect of on-site evaluation. This is the most recent paper published in Gastroenterology. Professor Itoi is also one of the co-authors. This study compared EUS FNB with and without on-site evaluation. As you can see, the accuracy is similarly high, over 95%, and tissue cores obtained more in FNB without those. And the procedure time was shorter without on-site evaluation. So if you use FNB needles, then you may not need on-site evaluation. Because as you can see here, with FNA needle, it's difficult to find the core in the specimen. But with the new FNB needles, as you can see, there are a lot of white core, so you can confirm you have enough specimen using this new needle without rapid on-site evaluation. So how many passes do we need for the accurate diagnosis? In 2004, one paper showed you need 7 passes to get the diagnosis in the pancreatic lesion. However, in 2017, even we using the FNA needle, because of the improvement of the needle, you only need 4 passes in pancreatic lesion more than 2 cm. However, in the small lesion below 2 cm, you still need 6 passes to get enough diagnosis. How about FNB needles? This is the left one is a paper from Professor Itoi's group with Francine needle 22 gauge. You need only 2.1 passes to get a diagnosis. And the right one is our paper. In this paper, we compared FNA and FNB needles. And with FNB Francine needle, with the 2 passes, you can get enough tissue acquisition rate. So I think with the FNB needle, we only need 2 passes for pancreatic solid lesions. And this is another paper using the FNB needle. MOSE is a macroscopic on-site evaluation. As you can see with the specimen, you can find a white core like this. So you can evaluate your eyes for the adequacy of the specimen. With this paper, with a single shot FNB, you can get a visible core more than 19%, and among them, over 94% has a historical core. So you may need only 1 pass in this paper. And then on the right, they measure the length of the visible core, and they found if you have more than 1 cm long core, then you can get a correct diagnosis. So these are the new method to evaluate the adequacy of the specimen using FNB needles. And nowadays, we need not only a tissue diagnosis, histological diagnosis, we need a genome profiling in the pancreatic cancer. In the NCCN guideline, in the metastatic disease, they recommend genome profiling in all the patients. Why do we need genome profiling? This is a paper from Know Your Tumor program. If we evaluate genome profiling in all the pancreatic cancer patients, about 1/4 of the patient had an actionable alteration. And if we can treat the patient with matched drugs, then as you can see, the survival was significantly longer, more than 2 years, if you can match the treatment for the actionable alterations. But if you cannot use this kind of genome profiling, then the prognosis was shorter than 2 years. So now we should perform genome profiling using a FNA or FNB specimen. And which is better, EUS FNA or EUS FNB for this purpose? As you can see on this slide, this is a specimen from the FNB needles. You can get more histological core compared to FNA. And this is a DNA amount. As you can see, FNB can provide more DNA for genome profiling. So I think we should use FNB needles for pancreatic solid lesion. And this is a comparative study of 19 gauge or 22 gauge FNB needle and a conventional 25 gauge FNA needle for pancreatic lesion. For the diagnosis of pancreatic cancer, as you can see, EUS FNA of small 25 gauge FNA needle is enough. But for the commercially available genome profiling called Foundation 1, EUS FNB can allow the assessment evaluation in 78%, but EUS FNA, it's only 14%. So if you want to perform genome profiling, we should use EUS FNB of 19 gauge or 22 gauge needle. In this study, the fork tip needle called shark core was used. So what needle do we need to use right now? We have a lot of needles right now, like a Procore, side bevel needle, EG short 3, and Acquire Francine needle, and the shark core. This is a fork tip needle. And this is a randomized control trial using 4 needles from Baradar-Jul group. They randomized 4 needles, and they also randomized the suction technique. They use suction or stylet retraction called slope or no suction. And they evaluate the diagnosis and also cellularity. And this is a study summary. For the best of cellularity, we should use Francine needle or fork tip needle, which are both FNB needles. And for suction technique, they recommend stylet retraction and no suction. So best overall outcome was obtained by Francine needle or fork tip needle and suction technique with stylet retraction. We also call it slope technique. So this is, I think this is a trend of EUS guided tissue acquisition. In the early days, we just want to confirm malignancy. So for this purpose, we just use a 25 gauge FNA or 22 gauge FNA needle with no suction or slope, because if you use suction, there's a blood contamination, which makes cytological diagnosis difficult. But because of the improvement of the needle, now we can get a histological diagnosis. So for histological diagnosis, we can use 22 gauge FNA or FNB needle with suction, because even if we use suction, blood contamination is not so important for histological diagnosis. And now we are in the era of genome profiling. For this purpose, we should use 22 gauge or if possible 19 gauge flancine needle or fork tip needle, FNB needle, with no suction or slow pull technique. Because if we have a lot of blood in the specimen, it may interfere with the genome profiling. So nowadays, we should perform EUS FNB using this kind of 22 gauge needle with no suction or slow pull. I will move on to biliary lesions. For biliary stricture lesion, we can perform ERCP or we can perform EUS FNA. So which is better? We all know ERCP guided tissue acquisition. Its sensitivity is not so high. It's about 50% in this systematic review. And the EUS FNA showed a 75% sensitivity. However, I think we should choose the EUS FNA or ERCP depending on the lesion. This is a report from Professor Moon's group. They performed ERCP first. And if the stricture is intrinsic, means cholangiocarcinoma, the diagnosis rate is 80%. And if it's extrinsic stricture from like a pancreatic cancer or lymph node metastasis, it's about 67%. And in the second procedure, if you cannot get the diagnosis in the first procedure, they perform ERCP again for the intrinsic stricture, and then they perform EUS FNA for extrinsic stricture. And with these two procedures, they got accuracy over 95% in both intrinsic and extrinsic strictures. So it depends on the nature of the stricture. If it's extrinsic, even if you perform ERCP again, you cannot get a diagnosis. So we should perform EUS FNA. And also the location of the stricture is also important. If it's proximal stricture, we can perform cholangioscopy and get a targeted biopsy. However, in the distal stricture, cholangioscopy is not so sensitive, so we can perform EUS FNA. And again, with this strategy, they reported cholangioscopy guided biopsy was more than 90%, and EUS FNA in distal biliary stricture, its sensitivity is more than 95%. So, if the biliary stricture is located in the hilar or intrinsic stricture, then we should perform ERCP or cholangioscopy guided biopsy. For extrinsic stricture like pancreatic lesion or lymph node metastasis, or if the stricture is in the distal, then we should perform EUS FNA for the pathological diagnosis. And we often encounter this situation. After biliary stenting, when we need a tissue diagnosis, we should perform EUS FNA with a stent inside the bile duct. As you can see on this image, if you have a metal stent, there is some acoustic shadow from the stent, and it's difficult to see the mass itself. And we are not sure if we perform FNA after stenting, does it affect the diagnostic yield or not. There are some studies, all retrospective studies, and the conclusion are very different from study to study. But these two studies show the metallic stent may lower the diagnostic yield because of this kind of acoustic shadow. So I think we should perform EUS FNA first before biliary stenting if you plan metallic stent. So I think this, we should keep in mind this kind of effects by the biliary stenting. This is my last slide. Now EUS FNB allows similar diagnostic yield with a less number of passes. And for clinical practice, I think for pancreatic solid lesion, 22 gauge Francine or fork tip needle with stylet pull method is recommended. And now adequate tissue sampling for genome profiling is needed for pancreatic cancer. So we should keep this in mind to get the right specimen. And for the biliary stricture, we should consider location. Is this intrinsic or extrinsic, or is this hilar or distal? And we should select the EUS guided tissue acquisition for distal or extrinsic biliary stricture. Thank you for your kind attention.
Thank you very much, Dr. Nakai. So, fantastic presentation as usual.
Thank you.
Thank you. So he talked on the not only USF current situation of USFNA, but also ERCP technique and the outcome for the pancreatic biliary diseases comparing to USFNA. So let's open discussion. First, we know the US FNB is much better than USFNA. So I guess, or somebody guess, FNB needle is very nice, but may cause a high rate of adverse event like bleeding or so sometimes pancreatitis due to the puncture. So how about your comment?
Thank you. So for the bleeding, sometimes we see bleeding during the procedure on EUS. So you can, if you put the Doppler on the EUS image, you can see the some bleeding on the needle tract. But in the end, usually it stops and there is no clinically significant bleeding. So I think if you use a 22 gauge FNB needle, the bleeding is not a big problem. And for the pancreatitis, if the lesion is small and if you have to go through the normal pancreatic parenchyma, I think there's a risk of pancreatitis or leakage, even using a FNA needle. But because with the FNB needle, you may have an increased rate of pancreatitis, but there's no data on that. So we should collect more data in the future.
Okay, thank you. Another question. So we know the already US FNA and the FNB is so fantastic diagnostic tool in pancreatic biliary disease. On the other hand, you know the as you mentioned, there's some paper on the needle tract seeding. So in case of a preoperative pancreatic cancer, so do you want to perform US FNA or FNB in all patients?
Thank you. So it's a difficult question. If it's a typical like a CT image in the body and tail pancreatic cancer, you may not need a US FNA diagnosis. But the problem is now we are giving a neoadjuvant chemotherapy almost in all the patients. So before chemotherapy, we need a historical diagnosis. So in clinical practice, we perform US FNA almost all patients, but we want to reduce the number of passes. So in those cases, I think we should use a loads to reduce the number of passes if possible.
Thank you so much. So same question to Dr. Yoshinaga. Maybe you think so. Please.
Thank you, Professor Itoi. So in my opinion, I should use FNA needle for pancreatic cancer in body and tail to reduce such kind of needle seeding. And as Dr. Nakai mentioned, so we should perform the less number of puncture. But of course, there is no strong evidence between needle pass and needle tract seeding, but we should consider about reduce the needle passes to prevent such kind of needle tract seeding.
You mean en bloc rejection area includes needle tract is okay, acceptable?
Yeah. Yes. Okay, in the region of the pancreatic head or alternate position.
Yeah, thank you. Okay, next, last question to Dr. Nakai. And we recently, we are interested in the genome profiling by US FNA or FNB sampling. So at that time, we frequently encounter the originally pancreatic cancer and liver metastasis with metastasis. So at that time, which is much better to get a sample from?
So we don't know the exact data, but the important thing is the ratio of tumor cells in the specimen. So if you have enough size for liver lesion, I think we should perform liver tumor biopsy. If it's too small, and then even USFNA or FNB for pancreatic cancer, we can perform genome profiling in about 60 to 70% in our unit. So I think we can choose pancreas or liver. It depends on the size of the lesion.
Thank you very much. So do you have any comment from Yoshinaga?
Thank you.
How is the National Cancer Center?
So recently, we get a lot of specimens. So I think the number of pass is increased because we have to get a lot of specimens. So again, genome profiling is very important because pancreatic cancer is a miserable disease, one of the miserable diseases because of the rate of death. So we have to get enough specimens. Not only pancreatic cancer, but also submucosal tumor, I think.
Thank you so much. Dr. Nakai, thank you very much. Nice presentation. Thank you.
Thank you so much.
So thank you very much, Itoi Sensei and Nakai Sensei. It's a great talk. And we would like to move on to the second speaker. So it's my pleasure to introduce Dr. Shigetaka Yoshinaga Sensei. So I would like to introduce him briefly. So he graduated from Kagoshima University at this moment. So I have to say, so he and myself, the university is a different university, but so prep school, I mean high school is the same high school. Anyway, so so he graduated from Kagoshima University, and the last more than 10 years he working at the National Cancer Center Hospital. He's a chief endoscopist of the National Cancer Center now, and he published lots of papers. And his interest covered very wide area, mostly focusing on US FNA and the diagnosis of GI cancer and the pancreas cancer. So, Shigetaka Sensei, please start your lecture.
Thank you, Professor Inoue, for kind introduction. So it's my great honor to attend Tokyolive 2021 as a speaker. So, and I very appreciate everyone who bring me here. So anyway, so I'd like to start my presentation. Please start my present video.
I'm Shigetaka Yoshinaga, a doctor of National Cancer Center Hospital, Tokyo, Japan. My topic is endoscopic ultrasound EUS for subepithelial lesion cells of upper GI tract. What is a subepithelial lesion cell? In the narrow sense, cell is a tumor arising from deep mucosa to proper muscle. In the broad sense, cell is a protuberant lesion or bump covered with intact epithelium. So, its etiology varies from non-tumor lesion to true tumor. How you can see 6 lesions? Can you distinguish between 2 cells and extrinsic compression? Generally, it is difficult by endoscopic findings only. In Japanese study, more than 30% lesions which diagnosed as subepithelial lesions by conventional endoscopy might be extramural lesions. But an international multi-center study to distinguish between submucosal tumor and extramural lesions showed endoscopy with EUS had a good specificity. Here we can see 2 cell-like lesions. Can you distinguish? EUS for the left lesion revealed heterogeneous hypoechoic tumor arising from proper muscle. This was this of the stomach. EUS for the right lesion revealed a cystic lesion outside of the stomach. This was a liver cyst. As shown, EUS is useful to distinguish between subepithelial lesions and extramural lesions. EUS is also useful to diagnose true cells. This is an EUS figure of GI tract wall. When we diagnose cells of GI tract, we should check an origination and an echo pattern of the lesion. When we perform EUS for cells, I tend to use a miniature probe. Of course, a conventional echo endoscope has good penetration. However, a miniature probe has relatively good resolution, and I can understand where and what I am scanning now. Therefore, I tend to use a miniature probe for cells which size is less than 3 cm. I will explain EUS features of cells using miniature probes. If a lesion is originated from second to third layer and its echo pattern is homogeneous and hypoechoic, it may be neuroendocrine tumor, NET, malignant lymphoma, or leiomyoma. This is a duodenal NET. EUS reveals a round hypoechoic and homogeneous lesion arising from deep second or shallow third layer. This is a gastric maltoma. EUS reveals a hypoechoic and homogeneous lesion arising from deep second layer. This is an esophageal leiomyoma. EUS reveals a round hypoechoic and homogeneous lesion arising from deep second or shallow third layer. If a lesion is originated from third layer and its echo pattern is heterogeneous and hypoechoic, it may be granular cell tumor or heterotopic pancreas. This is an esophageal granular cell tumor. EUS reveals a round hypoechoic and heterogeneous lesion arising from third layer. This is a gastric heterotopic pancreas. EUS reveals round hypoechoic and heterogeneous lesion arising from third layer with second fourth layer. Additionally, we can recognize a ductal structure in the lesion. Some other lesions originate from third layer have a typical pattern like these. However, it is difficult to diagnose hypoechoic lesion originated from fourth layer because the differential diagnosis of a hypoechoic fourth layer lesion is broad and includes benign and malignant lesion. This is a leiomyoma. EUS revealed a hypoechoic and heterogeneous lesion arising from fourth layer. This is a gist. EUS reveals hypoechoic and heterogeneous lesion arising from fourth layer as well. As I mentioned, the differential diagnosis of a hypoechoic fourth layer lesion is broad and includes benign and malignant lesions. Therefore, the diagnosis accuracy of EUS imaging alone has been shown to be as low as 43% in subepithelial lesions with third and fourth layers. In the early 1990s, Professor Tero Kozu in Japan and Professor Peter Wilmer in Denmark wondered if it is possible to get pathological specimen using EUS. Endoscopic ultrasound guided fine needle aspiration, EUS FNA, has been developed. EUS FNA is a diagnostic tool which can achieve pathological specimens from submucosal tumor, pancreatic tumor, lymph nodes, and so on by EUS-guided puncture. I will show you some cases. We can see the cell located on anterior wall of upper gastric body. EUS revealed hypoechoic and heterogeneous lesion originated from fourth layer. We diagnosed it as GIST, but biopsy specimen of EUS FNA revealed atypical spindle cells with positive for S100. So this was schwannoma. This patient had huge cell with ulcers. Of course, operation was considered, but this lesion was relatively big, so surgeon wanted to perform neoadjuvant chemotherapy if it was c-KIT positive GIST. Biopsy specimen of EUS revealed atypical spindle cell was positive for c-KIT. After taking imatinib for 6 months, the lesion became smaller and operation was performed. Usually, when we see ulcers on cell, we try to take biopsy from ulcer edge. In this case, we took biopsy and bleeding was occurred. In addition, we could not get any tissue except necrosis. This patient had a tiny tumor next to stomach. EUS revealed hypoechoic lesion and lesion was arising from proper muscle. Therefore, we diagnosed it as a myogenic tumor. 6 months later, the lesion grew rapidly. Biopsy specimen of EUS-FNA revealed atypical lymphoid cells. It was diagnosed as diffuse B-cell lymphoma. Chemotherapy was performed. Generally, percentage of adequate specimen of EUS-FNA for cells are 80 to 90%. Diagnostic accuracy ranges 90 to 100%, and complication rate is about 1%. Therefore, EUS-FNA is an effective and safe procedure. In our division, diagnostic efficacies are almost same. However, diagnostic efficacy for pancreatic lesions are relatively better than those of cells. Why is efficacy of EUS FNA for cells not so good? There are two big issues. When we perform EUS for gastric subepithelial tumor, we sometimes feel it is difficult to stick needle into the cell. These are some reasons. Usually, a convex endoscope has an oblique channel port, so if the region is stiff, a EUS scope is pushed back. And the gastric wall, especially the wall of greater curvature, is easy to extend it. Therefore, the lesion frees against punctures easily. One of the solutions is grasping the region using angle of EUS scope. After grasping, the region can be fixed. However, because of a sharp angle, we feel rigidity when needle is sticked. And if the lesion is located on the greater curvature, it is difficult to grasp. In such cases, a forward-viewing convex type EUS scope is useful. It has a straight channel port. It is easy to make holes during puncture. This is a comparison between conventional convex type EUS scope and a forward-viewing convex type EUS scope. A conventional convex type EUS scope has a wide scanning range and an elevator for forceps, but it has an oblique view and oblique channel port. A forward-viewing convex type EUS scope has a narrow scanning range and no elevator, but it is easy to insert and to make force. These are EUS images taken by each EUS scope. Scanning range of conventional convex type EUS scope is 180 degrees. On the other hand, scanning range of a forward-viewing convex type EUS scope is only 90 degrees. I will show you an EUS FNA case using a forward-viewing convex type EUS scope. Here, we can see an irregular cell on greater curvature of upper gastric body. EUS revealed a hypoechoic and heterogeneous lesion originating from fourth layer. We could stick easily and get enough specimen, and it was diagnosed as cyst. The second reason is the variety of cells. To distinguish cells, it is necessary to get a lot of specimens for immunohistopathological staining. As Professor Nakai already mentioned, recently, COVID-19 has developed a unique type of needle named shark core. This is a fork chip type needle, looks like a shark mouth. Recently, I had a chance to use shark core. I will show a case. This patient had a big cell in the third portion of duodenum. EUS revealed a hyperechoic lesion originated from the third layer. We diagnosed it as lipoma. However, we felt something strange because of its heterogeneity. So, we performed EUS FNA for this lesion. To tell the truth, I forgot to bring a thread out, but I could puncture easily. Enough specimen could be achieved, and atypical spindle cells with adipose tissues could be seen. After immunohistopathological staining, A1, A3, and S100 were negative, and MDM2 and CDK4 were positive. Finally, this lesion was suspected as liposarcoma. In conclusion, EUS is a useful tool for diagnosis of cells. However, we should understand it is difficult to diagnose some cells only by EUS alone. In such cases, EUS FNA is an important technique to achieve histopathological evidence from cells. Especially a forward-twin convex echoendoscope and a new type of needle, such as a fork tip type, may improve the diagnostic efficacy of EUS FNA for cells. Thank you for your kind attention.
So thank you so much, Yoshinaga Sensei, for your great lecture. It's really educational, and you covered the very wide area. Of course, the US, the importance of the US diagnosis, identification of origination of the tumor, and also based upon the image, we can make a tissue characterization. And you also mentioned about the newly launched, the conventional convex type forward view scope, US. So my first question is in the stomach. So now, if we detect some 2 centimeter or less submucosal tumor, even though stomach there is lots of GIST tumor very commonly we encounter. So I think it's better to do FNA. So if we identify the GIST tumor, we will proceed to the endoscopic resection of this tumor. So would you comment on the tumor around 2 centimeter or less in the stomach?
Thank you for your question. So if tumor less than 2 centimeter, but if we can get enough specimen to diagnose, and it's diagnosed as this, we should consider about resection. Now, so we have to use laparoscopic resection so far, and or we should consider about laparoscopy and endoscopy collaboration surgery. But so we should consider now, so it's very difficult to perform, but we should consider endoscopic resection if tumor is less than 2 centimeter, because we can remove safely and through the mouth. But if lesion is more than 3 or 4 centimeter, it's very difficult to remove through the mouth. So if the lesion is less than 2 centimeter, we should consider about endoscopic resection. But so we have to get evidence for the efficacy of such kind of endoscopic resection before we should choose such kind of resection.
Yeah, Yoshinaga Sensei, that's a point, I think. So, of course, a large tumor. So, after FNA and identification of the diagnosis of the tumor, then we will proceed to our LEX or laparoscopic resection. And the point is the less than 2 centimeter tumor. So if it's a benign basis, so leiomyoma or some other, we can follow the lesion. But you mentioned, as you mentioned, if it's a GIST, we have to proceed to endoscopic resection at this moment. Endoscopic muscle layer dissection or endoscopic subserosal dissection. Now we can do it, and also even when it becomes endoscopic full thickness resection, now we can close the defect using some flexible endoscopy technique. So yes, that's a point of this discussion. And you also mentioned that in such a small SMT, you routinely you recommend to use convex and forward view sonography to take the FNA specimen.
Yes, thank you for your question. So usually we can get enough specimen using conventional convex EUS scope, but as I mentioned, some area such as a greater curvature or antrum, when the lesion is located such area, it's very difficult to stick safely. So in such case, we recommend to use forward viewing convex EUS scope.
Yes, even a convex type EUS and the forward view or not, it's a conventional one or a new one, is depend on the lesion location.
Yes.
Okay. So, Itoi Sensei, Nakai Sensei, would you have any discussion of Yoshinaga Sensei's lecture?
So from myself, Dr. Yoshinaga, thank you very much for a nice presentation. So I guess a similar question. In case of a huge SEL, like more than 10 cm or more, at that time, so EUS FNA is not always necessary or not?
Thank you for your question. I think I should perform EUS FNA to decide the treatment strategy. If treatment strategy is already fixed, there is no necessary. However, if tumor is c-KIT positive GIST, we have to choose neoadjuvant chemotherapy. So if we diagnose it as a GIST, but if we want to perform neoadjuvant chemotherapy, we should perform EUS FNA before treatment.
Thank you. Thank you very much.
So, Nakai Sensei, any other question or comment?
Yeah, actually, I have a question for Professor Inoue. So we are in the near future, we're gonna reject endoscopically subepithelial lesion more and more. Mm-hmm. Do you think if we perform EUS FNA before endoscopic resection, does it affect the difficulty for the endoscopic resection?
So, yes, thank you very much. It's a nice point. On the same discussion was done in ESD. So when we take biopsy, so it causes a fibrosis in the submucosal layer. Then the resection sometimes become difficult. So particularly in the duodenum or colon. But I think the submucosal tumor, particularly it's derived from the proper muscle layer. So anyway, we approach to muscle layer. And then beforehand, so we have to make a right diagnosis. We definitely need it to talk to the patient and the patient family. So as I mentioned, benign leiomyoma is not necessary to take it out. If it's, for example, less than 2 centimeters, less than 2 centimeters, definitely not necessary to take it out. But GIST, even though it's less than 2 centimeters, I think it's better to talk with the patient. Resectability, so we will indication of the resection, we have to talk with the patient and patient family. So at the time, so definitely we need a histological confirmation. Then, so we will proceed. And of course, the GIST tumor derived from the fourth echoic layer. At least, even when we successfully done is at least endoscopic muscle layer dissection. In some case, the subserosal dissection. But so roughly 50% of the patient becomes a full layer resection. then we have to talk, so discuss with the patient and patient family, so potential risk of conversion to laparoscopy or some other, we have to talk to the patient family. So I'm not sure this is the answer to your question, but anyway, so definitely we need a histological data before treatment. Do you agree?
Yeah. Thank you.
So, any other question or comment to all the each other? It's okay. So, I would like to request the co-moderator Itoi Sensei, please conclude this session.
So thank you, Inoue Sensei. So I summarize these sessions. Thanks to Nakai Sensei, so we learn current status of US FNA, FNB in pancreatic biliary diseases in combination with ERCP. Also, thanks to Yoshinaga Sensei, we learn current status of Diagnostic EUS and the miniature probe in a submucosal region. So I guess both lectures sounds fantastic. We appreciate, I and Inoue Sensei appreciate your contribution to this conference. So we are running out of time of this session. So we will close this session. Thank you very much. Thank you.
Thank you very much.
Thanks so much.
Thank you so much.
Thank you.